Hi, my name is Jill Olmstead, and I'm a gastroenterology nurse practitioner. And welcome to the presentation this afternoon on MASLD basics. I've been in practice for over 20 years. I work for Providence St. Joseph Health, which is a large health system in Southern California. Talking to my patients and educating clinicians on MASLD and MASH, which used to be called NASH, is a common occurrence in my practice, and I think it's important for all of us to be aware of, and especially with the new and the changing information that we're having in this disease state. So this is the QR code that you'll use to record your attendance for this meeting. So make sure that you're taking a picture of this, and then you'll be able to get credit for continuing education for attending this program today. So the topic that I'll be going over the next 25 minutes will be MASLD basics. And as I had mentioned, there's been a change in nomenclature for a condition that's called steatotic liver disease. So this is the term that we use when we talk to our patients about fatty liver disease. So this is a common reason for visit that I'll see in the gastroenterology department. Sometimes primary care will send the patient just for the condition of fatty liver that's noted on an abdominal ultrasound. But as I tell my patients, the devil's in the details. So we have to look at the patient's history, really do a deep dive in seeing what could potentially be causing these symptoms and what is that person at risk for potential cirrhosis of the liver. So NASH has been changed to MASLD D or MASH. So it's MASLD, if you look on this algorithm, it's called metabolic dysfunction associated steatotic liver disease. So now the hepatology specialists are understanding that the condition of having fat in the liver is more of a metabolic disorder than a liver disorder. So now when I see patients, I'm really starting to pay more attention and looking at that whole body picture, which is going to be looking at what does their lipid panels look like, what does their BMI look like, because this now has turned into more of a multidisciplinary team approach in caring for these patients. So when you look at steatotic liver disease, there's an overlap between metabolic associated liver disease and increased alcohol intake, or MET ALD. So if you look at the middle of the algorithm, MASLD prominent, you're going to be looking at the number of alcohol drinks that they have per week. But if it's more alcohol predominant, you're looking at how many weekly alcohol grams that patients will take. So you can definitely see the increase in that. And it's broken down into average daily intake. So an important question when we're seeing a patient with a liver condition, whether it's elevated liver enzymes or with that abdominal ultrasound showing fatty liver disease, we want to get a good alcohol history. We want to remind patients that alcohol is actually a hepatotoxic agent, and that the amount of alcohol that a patient drinks certainly is going to affect their liver disease. Now, a key point that I want to share with my colleagues is that patients may come to you saying, I don't drink alcohol, but it's important to ask them, what is their history of drinking alcohol? They may have stopped drinking alcohol 1 week prior to seeing you in the clinic, or they may have stopped 6 months prior. But that 6 months prior history is important, because if they've had a history of 10 drinks per day 6 months or a year ago, that can play a role into the type of liver disease that you're seeing with them that day and counseling them. Other important aspect of steatotic liver disease is really looking at what is that specific etiology. It could, if you're looking at someone who has elevated liver enzymes, you're looking at drug-induced liver disease or DILI. You're looking at other condition, monogenic diseases, other types of disorders that can cause elevated liver enzymes like Wilson's disease, other also like alpha-trypsin disease, deficiency disease. Also, you want to look at cryptogenic. So cryptogenic means we don't know, we're not sure what's causing it, but certainly drug-induced liver disease that I had mentioned also is an important role in patients with liver disease. So you want to take a good history of prescription medications, which are usually access that we have on the EMR system, but also look at what they're taking, herbal supplements, vitamin supplements, and making sure you're documenting that as well. So the algorithm has changed that I had mentioned. So you have Maslow's definition is going to be the steatotic liver disease. And then you can break down that algorithm of, is there any metabolic activity that's taking place with your patient? So if there is, yes. In other words, do you see that they fit any of this adult criteria that you have or pediatric criteria? I didn't mention that I am an adult nurse practitioner, so patients that I see are 18 years and above. So this is a great handout to have printed and keep it in your exam room as a criteria, because I'm starting to show this to patients. And also it gives you a good criteria on, okay, what are my patients that I'm looking at that I could make this diagnosis of Maslow's. So you need to have 1 out of 5 of the criteria. Their BMI has to be over 25. Be mindful that if your patient is of Asian descent, then the BMI is actually lower. Look at that serum fasting glucose level, or look at their hemoglobin A1C, or the fact that they're type 2 diabetes and they're being treated for type 2 diabetes. Look at their blood pressure, look at their plasma glycerides, and look at their HDL. So if I see a patient, which is not uncommon, say a younger patient, say a young woman who's in their 30s and she's obese, presents with a abdominal ultrasound that shows hepatic steatosis, and her lipid panel shows that she has high total cholesterol, her LDL is elevated, and I'll question the patient, say that they've had those that abnormality in their lipid panel screening for, say, 6 months to a year. And I'll question her, have you talked to your doctor about being on medication? Have you tried lifestyle changes? And she said, oh yeah, I told my doctor I didn't want to start anything yet. I wanted to make some changes. And I said, well, it's been a year now. You may want to consider starting a medication, or else let's get serious on making those lifestyle changes, because now you're seeing this fatty hepatic steatosis change in your abdominal ultrasound, which means that we need to start making some changes now. If you look back to the algorithm, if the patient exhibits no metabolic criteria, then you're going to want to look at, okay, what are these causes of steatosis? And of course, if your patient has elevated liver enzymes, then you're going to want to start to work that up to make sure that there's not any other additional causes related to the hepatic steatosis. So we went over those following criteria below. So how will this change my practice? The change in the nomenclature, how it's changed in my practice is I'm speaking a different language. And in my EMR system, the ICD-10 codes have not changed between NASH and NAFLD. But what I've been doing is I've been looking for the terminology, and I've added the terminology in my EMR record to making sure that Maslow's terminology is on my patient's record. So studies show there's a 99% overlap between our Maslow's defined population and that historical NAFLD defined population. And all recommendations in the AASLD guidelines practice apply to the same patients. The key point is that the results from your natural history of this biomarker validation studies among these both populations are the same and applicable. So our terminology has changed, but what AASLD and other associations have done a great job in really giving us guidance and parameters to actually share with our patients. Many, many years ago, I remember patients would say to me, well, I thought everyone has a little fatty liver disease. It's not a big deal, is it? And then you have to take a deep breath and take a step back and say, no, the literature shows that patients with hepatic steatosis or fat in the liver causes metabolic disorders, which can cascade into having cardiovascular disease and actually leading that fat in the liver to scarring or fibrosis in the liver. So FIB-4 is a primary risk assessment. And in our Epic EMR system, we're able to use this score. It's a dot phrase, and it will give us a calculation. And you can share this if the patient has had the appropriate labs at that time. You can calculate it at that time. So if it's over 1.3, then you know that there could be a incidence of advanced fibrosis. So you want to be able to look at that and use that score. And what it does is it does compare to other imaging studies that are done, or imaging serologic studies. In our organization, what we'll do is use the FIB-4 score to determine if we do any of the additional testing. And that additional testing in our organization is to look at doing a FibroScan. I think there's still a lot of work to do with primary care management and teaching them to use the FIB-4 score. A lot of times what I'll see is that referral for fatty liver workup and abdominal ultrasound is done, and probably they'll have liver enzymes that were done too. But sometimes I'm even the first person that's doing that. Okay, so advanced fibrosis suspect specialty management. So I mentioned primary care. We want to educate our colleagues to use that FIB-4 score. And if you don't have it in the EMR system, what you're able to do is you can calculate it. It's an easy calculation that you can make even on your iPhone. So secondary risk assessment, this is where gastroenterology can come into play, is look at that immediate risk for fibrosis. So that's going to be someone who has a higher FIB-4 score, and you're going to determine, do I need to do a liver biopsy with this patient? Is this persistent enzyme elevation? And have I done the complete workup for the patient? So there's a lot that goes into this slide. We want to make sure that you've ruled out any other etiologies for the elevated liver enzymes if this is a fact. And now you want to stage that patient and see if there's any need for pharmacologic evaluation versus reassessing them in 2 to 3 years. These patients, I find, these are patients that I will see every 3 to 6 months in the beginning stage. And sometimes it will take over 1 to 2 years, it almost seems like, before patients truly understand the importance of this and making lifestyle changes. And these are conversations that are difficult and repetitive, and we have to emphasize that hepatic steatosis or MASH can cause cirrhosis of the liver, even though they're not drinking alcohol, and it's one of the top reasons for liver transplantation now. Looking at the different stages back here on this slide, you'll see that once you get to stage 4 of the liver disease, then we really have to implement cirrhosis management. This gives you a background of the global epidemiology of MASH in the world, and you can see that it's high. So this is not isolated to North America. This is an epidemic that we see internationally. So this is not something that's just specific to the United States. We have to be mindful that it can be across the world. And now with international travel, I'm seeing more and more patients from across the country, and this has to be a part of the conversation that we're having with patients. So looking at MASLD, there are 60 to 80 million Americans, and then MASH, which is more advanced fibrosis, is 15 to 20 million. The progression that you can go from a MASH from that is approximately 3 years, when you can go from that 20 to 30%, and then 20 to 30% of those patients over 2 years can develop cirrhosis. So you can see how rapidly this can progress. Now, when I say rapidly, we're looking at progression rates in MASH for stage 1 per 7 years. So 20% of those patients can progress to cirrhosis in 10 years. 10 years is not a long time when it comes to looking at someone who's been overweight and that has carried that extra weight and hasn't made that lifestyle change. That's why it's so exciting that we have a medication now that can help reverse that fibrosis or stop that progression. So this gives you this MASLD initiation and progression. So you can look at the normal liver and how it can change to MASLD. And then you start having the F1, F3 changes, which is then a cirrhosis, which is then hepatocellular carcinoma. So in patients in hepatology, we will start monitoring patients with cirrhosis and have an abdominal ultrasound and an AFP every 6 months because of that risk for hepatocellular carcinoma. Some studies are showing that the patients that we're seeing in our clinic, if they are an F3 and not diagnosed with cirrhosis, we should also be starting and monitoring them with hepatocellular carcinoma. And the PNPLA3, these are genetic markers that we use to monitor. So Maslow's guidance, so 2023 key points. MASH and F2 to F3 fibrosis is a higher risk for liver-related events and mortality at risk. The rate of progression of fibrosis and hepatic decompensation depends on that baseline of severity of the disease and the genetic markers. We're not currently in our community practice using the genetic markers, but we're certainly keeping a close eye on patients to monitor them. We're looking at their FIB-4 score, we're looking at their BMI, we're looking at their lipid panel. We're ordering a FibroScan. If the FIB-4 score is 2 or greater, then we're ordering a FibroScan, which will give us a greater definitive evaluation of the degree of the health of their liver from looking at separating out their score between liver fibrosis and liver steatosis. So it gives us 2 scores. If you're not familiar with what a FibroScan is, it gives us a fibrosis score and a steatosis score. Also cardiovascular disease, non-hepatic malignancies. This is part of the mortality of MASLD patients. And then death from liver fibrosis is predominance in patients with advanced fibrosis. So we're going to go over a case study right now. So this is a 55-year-old male who's referred for elevated liver enzymes. And it's interesting, I don't know if you can see in your own practice, sometimes patients will have elevated liver enzymes that have been mildly elevated for a long time. You know, it can be several years. This example is over 5 years. And this patient has had a 20-pound weight gain over the last 5 years. We can already see if we look at the list, he is obese, he's pre-diabetic, A1C is elevated, and he is hypertensive. No history of liver disease, rare alcohol consumption, and his current medications tells us that he's on a medication that's controlled for hypertension, and he has central adiposity. So current medications, we want to be mindful of medications that can be steatogenic or cause other etiologies we want to keep in mind that could be causing elevated liver enzymes. Remember that patients can have normal liver enzymes and cirrhosis. So we want to keep an eye on those types of patients and certainly do our due diligence with assessing these patients with hepatic steatosis. So medications to keep in mind are amiodarone, methotrexate, tamoxifen, 5-FU, corticosteroids, valproate, and antiretrovirals. Other etiologies we want to look at for patients with elevated liver enzymes are going to include your viral. So make sure that patient's been worked up to check for hepatitis B and hepatitis C, Wilson's disease, hemochromatosis. Look for lipodystrophy, HIV, look for malnutrition, look for celiac disease. Look for any other potential malnourished deficiencies in your patient. So the laboratory workup, look at that. We already talked about that. So you've done a complete workup for your patient with elevated liver enzymes. And you've done an abdominal ultrasound too. And the abdominal ultrasound shows that there was moderate hepatic steatosis. So the ultrasound, so back to our patient. So the ultrasound shows increased hepatic steatosis with the focal sparing. The contour is smooth. And the impression that you received is that there is hepatic steatosis, but no portal hypertension. And why is that important that we see no evidence of portal hypertension? Because that's also going to tell us that there's so much inflammation and engorgement and disease state in the liver that there's a backup and the portal system is impaired. So which patient still needs a liver biopsy? So stage 2, you're going to look at some isolated steatosis versus stage 3. And this will also determine your patients and if they do need a liver biopsy or not. So you're going to look at those non-invasive markers and you're going to look at your FIB-4 test. And if they're how I determine in my own practice, if they're indeterminate or if they're discoordinate. So if I have a liver fibrosis score and I've done a serologic testing and it comes back to be an F3, but my patient has recently lost 10 pounds and his lipid panels within normal range and his liver enzymes have come down, then I'm going to make sure I have a FibroScan on file and or repeat it, because that's to me is going to be more accurate than that serologic testing. So if the the fibrosis score on the FibroScan comes back 1 or 2, then I know I'm not going to have to need a liver biopsy. And the next point is that you want to make sure you're ruling out any other causes for liver disease. So a lot of times people will assume that a patient has fatty liver disease, but if there's any indicator that you need to make sure you're ruling out the patient's done a complete evaluation, then do that. And a lot of times you're not seeing this patient for the first time. It may be the 3rd or 4th visit, and you may be the first gastroenterology specialist within your group. So make sure you're going back to doing a good chart review to find out if that patient has had a complete workup in the past. So with this specific patient, we know that they have stenotic liver disease. We know that the patient met metabolic criteria. We've got 3 out of the 5 criteria. And we know that the definition is for this patient is going to be MASLD. So primary question to answer, does this patient have underlying MASH? Does this patient have any fibrosis? And does this patient have advanced F3 fibrosis? So we had actually, I mean, that's a point that we can bring up for discussion now. So, and if anyone has any questions, I can bring that slide back. But I think I may have given it away. So we know that the patient has underlying MASH. Does the patient have any fibrosis? Well, it came back that it was F2. So I think for this particular patient, instead of a liver biopsy, we should have a FibroScan so we can really get a understanding of what the patient's actual score is. And if anyone has any questions, you can feel free to come off of mute. You can also type questions in on the chat. That may be a little less intimidating if anyone wants to do that. But we're open now if anyone has any questions that you want to ask about anything in the slide set, specifically on hepatic steatosis.